Hello, I'm Dr. Patricia San Martín from Buenos Aires, Argentina, and I'm going to talk you about adrenal messes in and testicular adrenal rest tumors or TARTs in classical congenital adrenal hyperplasia due to 21-hydroxylase deficiency in adult males. 21-hydroxylase deficiency is the most common cause of congenital adrenal hyperplasia. In adulthood, most studies are reported in females, but dates on adult males are scarce. As treatment with glucocorticoids has only been available since the last 6 decades, it's not common to find patients older than 60 years with 21-hydroxylase deficiency that suffer from the long-term consequences of this disorder. Treatment with glucocorticoids and mineralocorticoids when needed reduce the risk of adrenal crisis and androgen sex controlling the disease symptoms. The presence of adrenal masses and testicular adrenal rest tumor has been described in 21-hydroxylase deficiency predominantly in inadequately treated patients. The aim of our report is to describe a series of classical 21-hydroxylase adult males studied at our endocrinology department in order to assess the following parameters: clinical features, hormonal profile, semen analysis, molecular studies, and the presence of TARTs and adrenal masses. Patients. This is a retrospective transversal study of adult patients over 18 years old, 8 patients with classical 21-hydroxylase deficiency, 7 were diagnosed in their infancy, and 1 consulted us due to an adrenal incidentaloma at 28 years old. We recorded the clinical data, the history of adrenal crisis in childhood, treatment type, dose, and compliance. Compliance was established by assessing a regular attendance to clinical control and uninterrupted treatment. Weight, height, body mass index, blood pressure, present or absent on congenital stigmata, and urogenital examination were assessed. In laboratory studies, here we can see the tests we perform and the method used. I would like to remark that androstenedione levels in the mid to upper range were considered as appropriate for treatment goal. Glucose level, plasma ionomer, and cholesterol triglycerides were measured between 8 and 9:30 after a 12-hour fast. Molecular studies were performed at the Molecular Biology Laboratories of the Department of Endocrinology at Garrahan Hospital, Buenos Aires, Argentina. The 11 most common mutations were studied using DNA from leukocytes in peripheral blood obtained according to standard methods. We performed testicular examination, semen analysis, and abdominal computed CT scan. Testicular volume was measured using infrared orchidometer. Additional testicular ultrasonography was performed. Semen samples were obtained after a sexual abstinence of 3 to 5 days. And non-concert abdominal CT scan was performed according to the protocol for adrenal glands, including thin slide images to determine size, aspect, and lipid contents. A patient were evaluated whose mean age was 25.6, 3 were salt wasting, and 5 were by sample viralizing. The mean height was 1.62, mean BMI was 24.7, and mean systolic blood pressure and diastolic blood pressure were normal. None of the patients had arterial hypertension, neither Cushing features. In table number 1, we show clinical data, classical 21-hydroxylase deficiency in 4, basal 17 hydroxyprogesterone levels, molecular genetic study, fertility status, and treatment. The 7 patients with previous diagnosis show irregular adherence to treatment since childhood. Patient A was recently diagnosed and had not begun treatment at the time of hormonal studies. The most frequently used glucocorticoids were methylprednisolone and hydrocortisone. 4 patients received also fludrocortisone. In table number 2, we see laboratory studies. All tests were between normal range, and the androstenedione was in the mid to upper normal range. That was our goal of treatment. In table number 3, we see testicular evaluation. All patients underwent testicular examination. 2 patients, 1 and 2, had testicular hypertrophy, and additionally 1 patient had a palpable tumor. In 6 out of 8 patients, testicular ultrasonography was performed that were identified in 5 out of 6, and they were bilateral in 4 out of 5. Patient 4 required testicular biopsy due to TART growth. In table number 4, we show semen analysis that was performed in 5 patients. Azoospermia was observed in 2, and the others were also pathological with severe teratosospermia. In table number 5, we see adrenal masses. No contrast abdominal CT was performed in 5 patients, and nodules were identified in 4. Only 1 patient, patient A, was operated, and the histological diagnosis was a cortical adrenal adenoma. Discussion. Although this series is small, we consider concomitant clinical, laboratory, and molecular features, as well as the presence of adrenal masses, TARTs, and semen analysis. In Argentina, the neonatal screening program law was implemented in 2007 with a CIH incidence of 1 in 89,37. Patient A, who had no previous diagnosis, was born in a neighboring country where there was no neonatal screening performed at the time of his birth. TARTs were palpable in only 1 patient, but testicular ultrasonography showed to be essential for detection of the tumor in the other 4. In the literature, prevalence of these tumors vary from 0 to 94, depending on the different means of use and the age of the selected patients. There was a high rate of bilaterality in agreement with the findings by other authors. Patient 4 underwent bilateral testicular biopsy due to TART growth. He had the highest gonadotrophin levels in the series, such as impossible damage to the normal testicular tissue and obstruction of the seminal tube associated with oligospermatogenesis. In the patient who performed sperm analysis, severe teratosospermia was found. Regardless of the presence of TART, the existence of other alterations associated with 21-hydroxylase deficiency may affect normal sperm production. Patients with bilateral and larger TARTs 4 and 6 had azoospermia, suggesting that the presence of the tumor directly affects spermatogenesis. Adrenal nodular images were detected in 4 out of 5 patients who performed CT scan. In patients with classical 21-hydroxylase deficiency, the incidence of adrenal masses is higher than in the general population. They are usually found under poor disease control, which could also account for large-size tumors. At Howard Department, adrenal CT scan has been routinely requested in patients with 21-hydroxylase deficiency since 1993, and we find a high prevalence of adrenal masses in classical CIH. We previously supported 35 women with classical adrenal hyperplasia, and we could perform CT scan in 16. We performed a CT scan in 35, and we found adrenal masses in 16. These were 23 from the adrenal masses. Surgery was performed in 4. 2 were cortical adenoma, 1 adrenal carcinoma, and 1 gigant bilateral myelolipoma. As conclusion, we believe that the strength of our study relies in assessing together clinical presentation, molecular biology, adrenal and testicular imaging studies, semen analysis, and compliance to treatment in adult men with classical 21-hydroxylase deficiency. Limitation to take into account the small sample size, the retrospective nature of the study, and the fact that not all the tests were performed in every patient. Nevertheless, we consider that our study contributes to the clinical approach in the classical 21-hydroxylase deficiency adult male population. Prospective studies with a larger sample size and a longer follow-up are needed to draw further conclusions regarding this disorder. Thank you very much.